This conference will now be recorded.
All right, good evening. Today is what, August 10th, 2026. This is the AnCan Low and Intermediate Risk Prostate Cancer Support Group. I'm Bill Franklin. I will be your lead moderator tonight. I'm being assisted by Mr. Stuart Jordan, Mr. Boykin Jordan, who always say that they are no relation, though I think they're cousins or distant cousins, and Mr. Rick Davis, and our other group members that will be happy to discuss their opinions with you about your path and their path. So if you're new here, we're going to get to you first. I think we have a couple of them on my, well, only one on my list now, since Mr. Lead is going to the advanced group. This is a peer-to-peer support group. Nothing that you hear in here should be construed as medical advice. We're here to share our collective experience with you and answer your questions. And we hope we'll provide you with the information that you need. But anything you do hear in here, we encourage you to take to your doctors. Is there anything I missed? I probably missed something. But before we get
no recurrence.
Oh, yes, we do not discuss recurrence in here. If you have prostate cancer recurrence, then you belong in our advanced and high risk support group, which meets tomorrow night at 6 p.m. Eastern in this same room. So before we begin, I will acknowledge the sponsors that make some of the work that we do here possible. So our current sponsors are Novartis, Blue Earth Diagnostics, Foundation Medicine, and Telix Pharmaceuticals. All right, so without any further ado, I think I will get started. All right, so on my list, first up is we have Jeff. You said you were new.
That's right.
All right, so Jeff, we take the new guys first, and we give you kind of like an intake questionnaire, figure out where you're at and how we can help you out. So bear with us while we ask you some questions. If there's just something you don't know, just say you don't have that yet, and we'll discuss why we think you might need it. So how old are you?
I'm 59.
All right. And where do you live?
Philadelphia.
All right, Philly. Someone else in here is from Pennsylvania, aren't you? We had someone in here. All right. So when were you actually diagnosed with prostate cancer?
In about January of this year. January, February.
Right. January 26th diagnosis. And if you guys can hear my keyboard clacking, I'm sorry. My quiet one broke and I had to replace it. So I take notes while I talk, so I apologize. What was your diagnosis? Did you go because you had did you get a high PSA? Did you have concerns that you took to your doctor? Or?
Yeah, it was PSA reading. It had been going up for several years in a row, and it finally went above 4. It got close to 5, and so they decided I should have a biopsy. So I did.
So before you had a biopsy, did you have an MRI?
I had an MRI last year, and it didn't show anything.
Was that before your biopsy?
That was before, yeah. And then the PSA got higher, and I did the biopsy this year, and they then followed up the biopsy with another MRI, which this time showed a lesion.
Okay, so they didn't use the MRI as a guide, like a MRI fusion guided biopsy.
They did that for a second biopsy, which I had more recent.
Okay. So
yeah, I don't know if I'm supposed to just give you the whole story or answer questions.
No, just answer questions, so we'll keep on track.
Okay.
So you've had two biopsies.
Yes.
Okay, that's how far apart were the biopsies?
The first one was in January. The second one was in July. And the reason for it was that we were thinking about potentially doing active surveillance, and the urologist wanted to do a targeted biopsy.
So the second one was targeted biopsy. You had an MRI that showed a lesion, and they targeted that with the biopsy, right?
That's right.
All right, so we got there. What do you know what your Gleason score was from that biopsy?
It's a 7, which is 3 + 4.
All right.
But it showed cribriform pattern.
All right.
Which, I knew nothing about until now, but I understand that makes 3 + 4 kind of worse than you would think it would be.
Did they say if it was, did it outline whether or not it was large cribriform, small form, large form, or?
No, and I didn't know to ask.
Okay, yeah, that's all right.
Would I be able to find that out if I looked at the report?
If it didn't say it specifically in the report, then you'd have to have the pathologist go back and tell you that. But we'll get to that in a minute. So do you know how many positive cores you had?
Yeah, they did in the part where they targeted the lesion. They took 4 cores, and they were all positive.
Okay.
And they did, a sample of the rest of the prostate too, and found only 1 other out of like 12. So it seems like there really is 1 significant lesion.
All right. So now this kind of ties into the cribriform. Have you had any kind of second opinion read on your biopsy pathology?
No, and that was actually one question I had, was whether that was something that
is something that we definitely recommend. If you go to the chat window, are you familiar with the format here? If you look in the upper right corner, you'll see some icons up there. You see a couple that look like speech bubbles.
Yep.
If you click on that, that's our chat window. The very first post is a pin, and that is a web page on our website, which recommends the individuals that we think are probably the best at giving second opinions on prostate biopsies.
Oh, great. Okay.
With Dr. Jonathan Epstein being the preeminent pathologist for prostate cancer in the country. So, but the other 2 individuals, Dr. Zhao and, I'm sorry, what's the other guy's name, guys? Miller? Did I get it wrong? But the other 2 individuals are also really highly regarded. Dr. Zhao was Dr. Epstein's student, actually, so was trained by him.
And so I could contact them and then have.
Yes, if you click on it, it'll take you right to our webpage, or you can copy that link also. But if you go to our webpage, it'll tell you, it has some brief instructions on how to get in touch with them. But yeah, you contact them and let them know that you're going to want to do this. You can also go to your doctor who's holding your report and tell them that you want your biopsy read by another pathologist, and that one of these individuals is the one that you want it sent to. Now, if you go to your doctor and you tell them you want it sent to them and they don't know what to do, I know that Dr. Epstein, you can always tell him that you ran into that problem, and he'll reach out to your doctor and get it sent to him. I'm not sure about the other 2 doctors, but there's a way.
What is it that gets sent?
Problems. It's a process, right? So it can take a week or 2 to get done, maybe even 3. But most people that talk about getting second opinions in here, they've usually gotten their second opinion within a month.
Okay.
So from what you've told us here, I didn't ask you the 3 + 4 is 7, that the positive areas that they did have, was there a percentage reading on how big the core was and what percentage of it was positive for 4 on the Gleason score?
That was like 5 or less. It was apparently small. The part that was 4.
Percentage wise?
Yes.
Okay. Yeah. So you have plenty of time to get a second opinion. You're not in a rush to get something done.
Right.
Have you had any other kinds of tests done yet? Has your doctor recommended anything else?
You mean beyond the MRI and biopsy? No.
So there's like
And
genetic
PSA.
testing. You can get germline testing done, or there's a test called a decipher test, which is an analysis of the tumor. So, but I don't think you need to rush into that right now. Go after that second opinion first to see what they think. That way, a lot of times they'll come back and say that it's not as bad as it looks, or it's the same, and then you've had two good pathologists look at it, so you can pursue your path from there. So has your doctor recommended anything based on the biopsy? Are they recommending a course of treatment? Have they told you to go see any other kind of doctors? Or?
So yeah, the urologist after the first biopsy, I asked if active surveillance would be something that I ought to consider. He was a little reticent about it, but ultimately said, sure, he thinks that would be okay if a confirmatory biopsy showed that it was no worse than the original said it was. So we did the second biopsy, and that one showed the cribriform pattern. And so his opinion is that I should have surgery. I also had an appointment with a radiologist
Okay.
After the first biopsy, but before the second. And her opinion seemed to be that that radiation would be a fine solution too, but she seemed to also think that at my age, surgery would be the recommended way. I have a follow-up radiology appointment next week.
With the same doctor, or?
It's a different radiologist this time, simply because the other one's on leave. But I have a different radiologist this time who I'm going to talk to, and I think part of what I wanted to kind of figure out tonight from you all is, what should I be asking that I don't know?
All right. So I did tell you we cannot give you medical advice, but the gentleman has his hand raised is a doctor. He's not going to give you medical advice, but he's going to give you advice as a peer. So Mark,
Sure.
Go ahead.
Okay. So one thing I would be sure to ask about, one of the things that they're going to tell you is that younger people do better with surgery. What they don't say is better than what. If younger people are getting surgery and someone 85 is getting surgery, the person who is 55 is going to do a lot better than the person who's 85. And I think that's where they kind of got those statistics. At any given age that I know, there's no studies that I've seen that say that people with surgery are going to do better than people with radiation. And if you're in your 50s and you have surgery and you are incontinent after, and you have erectile dysfunction, you could be facing 30 to 40 years of leaking urine. Now, it's not for everybody. Not everybody has that problem ongoing, but you're not, almost no one, 1 to 2% at most, are going to have some incontinence or leakage with radiation. With the genetic screening before the SBRT, it cuts down the risk of the long-term problems with that as well. And then there was another look at the PROTECT study. And there's obviously flaws in that study, but the PROTECT study looked at people where the disease was confined to the prostate, and they did either radiation, surgery, or active surveillance. And they found no big difference except in those patients with a large cribriform. And they found that the patients with large cribriform who went ahead and did surgery were 3 times more likely to recur than they were if they did radiation therapy. So with cribriform, I don't know that I would rush into surgery. At your age, I don't know that I would rush into radiation. I'm sorry, rush into active surveillance and just sitting there. You just don't want those complications.
So, okay, so you say don't rush into surgery, don't rush into active surveillance, meaning maybe radiation is a better option than folks seem to think it is?
I think it may be, and the real question is to confirm your pathology about whether it is cribriform, because if it's extensive cribriform pattern in there, they're going to tell you, yeah, we think we might see some or a little bit, or it's small cribriform, not large. So one of the fellows who did the most cataloging on that is in our list, and his name is Jesse McKinney at, is it Cleveland Clinic or Case Western, one of those in Ohio places. And you really need to know what the pathology shows, and we're not getting that from local hospitals. The story comes back from Dr. Jonathan Epstein that about 30% of the biopsies that he sees, he has to rejigger the diagnosis because the original people didn't get it right. So you've got time, you've got to get some answers and get the right answers, but don't rush into surgery because there are just too many side effects and no particular advantage. One other myth that they're going to tell you is that if you do radiation first, then you can't do surgery later. And that's actually a benefit because you wouldn't want to do surgery in the beginning if you've done your homework. And in the end, if you've had a recurrence, you can do just as well with various focal treatments, with radiation treatments like theranostic treatments like lutetium-177. You can do chemotherapy. There are all kinds of things that you can do. So the idea that if you do radiation first, you've shot your wad is just not true.
I see. So it is true that if you do radiation first, you will not later do surgery, but there are lots of other kinds of things you can do like you're talking about.
Well, so that's not entirely true. You can do surgery, and there are docs who are experienced in doing surgery after radiation. The question is that if there's no reason to do surgery up front as a first line treatment, and there's no reason to do it for treating recurrent disease, then it shouldn't really matter because you do have other alternatives. So if they're trying to scare you into doing surgery, which a lot of people do, step back and think twice about the information you're getting.
Right. Okay.
Yeah, I neglected to ask Jeff, where you were getting treated?
University of Pennsylvania.
All right.
Who's the urologist?
His name is Shaw, which is spelled X-I-A, like the Chinese spelling of Shaw.
I don't know him. Who have you seen for your radiation? Who have you consulted with for radiation so far?
The doctor is named Vapawala.
Yeah, she's great. She's one of our favorites. We love her. And she's great. And I don't think you can do a lot better anywhere in the country than Dr. V. Is she the one who's out right now, or is she the one you're going to see?
Yeah, she's the one I saw, and she is on leave. She's taking a sabbatical until October, so they have me going to see somebody else next week. I could see her again, but not until October.
I mean, you're not in a desperate hurry. Take your time, and if you're going to get radiation, stick with Dr. V.
Great.
She's the best. And
You're
she knows,
in good hands.
you can tell her. You can tell that the AnCan guy said nice things about her. No,
I thought she was very good in person. She was great to deal with.
She's super. And actually, it's interesting. She just wrote a piece, an interesting piece that appeared in the Journal of Clinical Oncology about 3-4 weeks ago. And under the title of Business of Oncology. And I read it and I sent in a response. And in that response, because she was the final author on, there were only 3 authors. She was the final author. It was written by all three were from Abramson. And I wrote in there how much we like Dr. Vapiwala. And the editor wrote back and he said, you have to take things like that out. You can't make personal statements. But we'll print what you want to say because we think it's a good message. So I've actually rewritten it and it's gone back and it should appear. But essentially what we were saying is that when it comes to radiation, this is important for everybody listening to this group. When it comes to radiation, the elephant in the room is that the radiation oncologists often don't tell you about all the different options that are available to you in terms of radiation. So, on a very basic level, we have brachytherapy and then we have external radiation. Within external radiation, there's a whole number of different types, and some are more, they may not be better, but they're more convenient for the patient. And what happens too many times is that the radiation oncologist tells you what they got. And they don't tell you about the other options. And you as a patient don't know to ask. So you don't finish up in the right place. And that's what my letter is about. And I think it'll get published. I hope so. But I think that Dr. V didn't address that. And I think it's the elephant in the room. And if you do decide to do radiation, then she will talk to you about all the different types, provided you ask.
Right. And when I did talk to her, she said that if I decide to go radiation, there would be some kind, I don't remember what she called it, but there would be some kind of test in advance.
Yep.
And after that, she would then have a recommendation for me on what kind of radiation I should get. And that
test, if you Google, somebody's going to be kind enough to put the link, I think, in the chat window for us. But if you Google Prostox, Prostox, on our website, you'll come up with 2 webinars. The most recent webinar is the one you want to listen to. The older one's good too, but the test has gotten better. And that will tell you whether you're a candidate for what type of radiation you're a candidate for. It won't talk to you. Oh, Bill put it in.
Wait a minute.
Yes, he only sent it to me. And that's that. There you go. But Bill put it in. That will only tell you what type of radiation, but not brachytherapy. So you also want to talk to, because you may be a candidate for brachytherapy. You may be a candidate for certainly high dose brachytherapy. So all these things are things that you want to talk about with Dr. V when she gets back. God bless her. She's on a sabbatical. She deserves it. She works very hard.
Yeah.
So yes.
Okay. Do you have, so you haven't heard of my urologist. Do you have anyone in Philadelphia that you know or like?
Well, the urologists we like are actually at Fox Chase. There's a couple of Fox Chase that we really like. So, when we don't have a bias really to Penn or to Fox Chase. There are, you don't need a genitourinary medical oncologist, but that we like them at both places. We like some of the radiation docs at both places, but I'd say Dr. V's our favorite in the Philadelphia area. And I would say Dr. Correa is probably our favorite urologic oncologist. Don't ask me why, but the UPenn, none of the UPenn urologic oncologists, the surgeons, really have struck a chord with us. But there's a couple of docs we really like at Fox Chase, and we've had some good luck sending people over there. But I wouldn't trade Dr. V.
Right.
So it makes it a little difficult for you. But if you wanted to get a second opinion of Dr. Correa, and then you can decide where you want to stay, that would not be up. We'll put Dr. Correa's details in the chat window for you. I'll do it right now.
Good.
Jeff, I was talking to you, but I was muted. So, I'm assuming you're signed up for our group. Does your last name start with a B?
No, mine, no.
It doesn't.
I didn't sign. I just logged in and connected to the group. I didn't even know there was a sign up.
Someone named Jeff, whose last name starts with a B, that just signed up like yesterday. So I made an assumption that it was you, but
no.
That's all right. Well, the other Jeff's not here tonight, so. Yeah. So if you want to put your email in the chat window, we can get you signed up for our reminders, so you'll know when the meetings are. It's not a requirement, but if you want to do it, you can.
Okay.
If you don't want to share your email with everybody, you can reply privately just to me.
Okay, I'll do
All
that.
right, anybody else got anything for Jeff?
I have it here on my phone, so it's not so easy for me to do this stuff right now. Yes. Can I ask you one question?
Another easy way, another easy way is you can send it to info@ancan.org, info@ancan.org, and Bill will get it, and we'll put you in there. We have a bunch of other groups too that you might be interested in, or you might not. But anybody who's already seen Dr. V is treated royally in this group.
Yeah.
I'm glad.
Did you say you had another question, Jeff?
Yeah. So one of the things that in trying to decide between surgery and radiation is that what I'm being told is that while the side effects of surgery are, in my mind at least, can be really bad up front, the side effects of radiation increase or may increase over time. And that for somebody who expects to live 30 more years, that's why the folks figure that the surgery is a better option early on. Because by the time you get to the end, the side effects get worse and worse from radiation. And I haven't really been able to get a sense of how true that is.
Well, I have an opinion on that. Mark raised his hand, but I'll say something first. I had radiation treatment, but before that, I had a prostatectomy. We don't discuss recurrence here, but I'll tell you, I had radiation treatment. I had a prostatectomy, I had radiation treatment, I had androgen deprivation therapy. I've had it all, right? Not everything, but hopefully I don't have to have anything else. I was treated 11 years ago, and I had side effects from the radiation for about a year, and any other side effects over the course of the last 10 years have been very, very minimal. So that cumulative thing, maybe I got it maybe in another 10 years. I don't know, but there is a lot of evidence that radiation can cause problems down the line. But every treatment has side effects, and even a prostatectomy can have, like Mark was talking about earlier, a prostatectomy can have lifelong side effects, right? So go ahead, Mark.
So can I just say one thing, Bill? Would you say a few words about the nomogram? We posted the link in there, but we didn't explain to Jeff what it was and why he might want to do it.
Yeah, Jeff, the Memorial Sloan Kettering Cancer Center has a kind of like a questionnaire on there called a nomogram. And what that is a collection of questions that ask you about your diagnosis and your course so far. And it's a comparison of, I don't know how many other patients, thousands and thousands of patients that have been through the same thing. So they've been able to come up with some statistics on, the probability of what might happen to you down the road. And that's always a good thing to look at. They're a little dated, I think. I don't know the last time they were updated, but it's good. It's another good source of information to have. So the link is in the chat window, but like you said, if you're on your phone, if you can't get it, if you ask me when you send an email to info@ancan.org, I'll get you the info.
Yeah. Okay.
But Jeff, the bigger reason to do it is that it'll give you an indication of how likely it is that surgery alone, what the percentage is that surgery alone will cure you. I shouldn't say cure, I'm sorry, will handle the problem. Okay, because we don't believe that you can actually cure yourself unless you have 3+3 disease. If you have a 4 in the number, you get to be like me or Mark Perlow, Dr. Mark, where you get a durable, continuing remission, but it can always come back. We have gents in our advanced group where it's come back after 17 years, 20 years, and that's the issue. And that's why we don't talk cure in prostate cancer, because it can happen. Now, what this nomogram does is tells you the likelihood that surgery alone will handle your problem and how likely it is to recur. And that's really what you want to know when you make the decision, because otherwise you can be in a situation like Bill, where he was around your age younger when he was diagnosed, and then he found out that it didn't take care of it and he needed radiation as well. And that's what we try to avoid. We don't want you to have to do surgery and then find that you've got to do follow-up treatment as well. The only problem with that nomogram is that it's constantly updated, Bill, but the questions don't take into account things like crib reform. Because back in the day, I ran that 17 years ago, and they weren't calling out crib reform. So it's not part of the decision-making function. And we do now know that certain types of crib reform bode more seriously.
Did you have any?
All right, Mark, are you still there? Mark muted and turned off his camera. Govinda, you had a question or a comment for Jeff?
Yeah, I had a comment. I just, sorry, my camera is not working, so I don't. I had radiation, SBRT, about 10 years back. That time my Gleason was 4+3, and the side effects were there for between 4 months to about 8 months. After that, it subsided considerably. After about a year or year and a half, it was almost back to normal. And after 10 years now, I have no appreciable side effects. I had to go to washroom only once in a night maximum. I'm quite healthy, and my last PSA reading about 3 months was 0.048. And my experience has been extremely good with SBRT. And I did quite a bit of research before I took the decision. And the conclusion I came at that time was there are more side effects if you go for a surgery compared to a advanced treatment like SBRT. And this treatment has improved considerably in the last 10 years. And the treatment you will get under this is much better today. This is my experience. Things changes from people to people, but I've been extremely happy with the treatment, and I had no other treatment, and only SBRT. At that point of time, 10 years back, nobody used to prescribe an ADT or hormone therapy, so I didn't have that also. It's just my case. It may differ from person to person.
Did you have a decipher test, Jeff?
No, he hasn't had any additional testing yet, Steve.
I have not had that.
Okay. I kind of went through the same thing, but I had cribriform and borderline IDCP, and my decipher score was quite high. So I never really thought about surgery because I was more afraid of the leakage issues. But I think, in retrospect, I wouldn't have picked it anyway because of the, higher risk that I had. I ended up, I'm on ADT now, and for 6 months. But I think, as has been said, of course I didn't have radiation 10 years ago, but I just had it, and I had it with Dr. Keyshawn MR Linac, and I think that's probably among the best you can get. I mean, not so much, the doctor, yes, and also I think the treatment. So I think the side effects are less. Ask me again in 3 years, but it's been okay. The worst part I've had to deal with was the ADT part, actually.
Mm-hmm.
I'm going to ask you again in 10 years.
Yeah. I don't want to think about that.
Mark, did you have some technical difficulties?
Yeah, I did. I guess internet was challenging me. I was just going to say that radiation therapy today is nowhere like what it was 10 years ago. The amount of normal tissue that they radiate is far less. Steve and I both had the MRI Linac at UCLA, and it's about 60% less initial side effects. And they've now followed that out 2 years. And with that system, you're going to see less radiation. I think both Jefferson and Fox Chase have MRI Linac. UPenn, I don't think it does. UPenn offers proton, but with the proton machines, they have not yet uniformly cut the margins of normal tissue that they radiate around the prostate to make sure that they're getting the whole thing. I think the other thing is that we've changed significantly how we grade this and how we evaluate the pathology and what all that means. So I don't know that 10-year data is going to explain something to you. There was a Harvard study that said, we don't think there's any increase in cancer, in secondary cancers after the newer, more focused radiation treatments. So this isn't the same. If you're using an MRI Linac or CyberKnife, it's different than getting a TrueBeam system or one of the other systems that are out there. Your prostate can move when the beam is on. The new systems will turn off the beam if there's any movement. The new systems allow for daily reconfiguring the treatment if there's any swelling or shrinkage in the prostate due to the radiation treatment, and that can make it safer. And then the collimation, meaning how accurately the machine can focus the beam so it's getting just where they want, that's changed. If you look at a proton machine, all the energy is coming in from two directions. So it's a lot more. And they talk about the Bragg effect. But the problem is that if you have the Bragg effect, that all the energy is dumped in one spot and that spot moves while the beam is on, you're in trouble. That's not going to happen with an MRI Linac machine. So they are far superior. And then also you can do the Prostok's genetic test to see if you have risk for the higher rate of delivery. But in terms of treating the disease, the higher rate of delivery may offer benefits in cancer cells versus side effects. So get answers. I spoke to 3 or 4 radiation oncologists before I decided. And in your situation, you certainly have the time to do that.
Right. Appreciate that.
All right. So check out those second opinion things. Send me your email at info@ancan.org. And if you have any further questions, you can send them there too. And by all means, come back and tell us what's going on.
Will do.
All right. Anything else we can help you with? Last chance.
I just want to listen to the rest.
All right. All right, we're going to move on.
For now.
Brian, you're up next. I will tell you, we don't want to get too far into what your results were because of this is the low group now. So, but we do want to help you out. So,
yeah. So, right. So, I guess I got to move to the high risk group. Is that? It sounds like. I think I do.
Yeah. I mean, I'm glad Rick is here and. I'm not an expert at reading the PSMA test, but I mean, just from looking at what David sent me, you have metastasis to your bones. Yeah. It seemed to be a small amount to the ribs, but you also have lymph node involvement. So yeah, you've got N1 disease.
Yeah.
You were going to say something?
Yeah, Bill, I don't want to say you have metastasis to your bones because we cannot say that from the PSMA. The reason being,
sometimes if you have a cracked rib or something, if you've ever cracked your ribs or something like that, sometimes there can show some uptake there. But
I put my rib through my lung a long time ago when I was like 25.
Right. So the point is, Brian, that may show up, and when we see these SUVs of 2.5, 2.6, 2.7. We don't want to rely on them. We just had a guy in the high risk group get treated with a lot of hormone therapy, and now that he's in treatment, he was at Walter Reed. And the GU medical oncologist or the medical oncologist, they don't have a genitourinary medical oncologist. The medical oncologist said, well, I think you may not have any metastasis. We don't really know. And we've sent him to another doc that we trust for second opinions. The issue with you is because he had similar SUVs to what you have in your ribs. The issue with you is that there are a couple of lymph nodes, the sacral and the internal iliac, that have much higher SUVs. Like, I think one of them had 10.5 and the other 8.
Yeah, 10.5.
That's high enough that we have to take that seriously. And so we would prefer to speak to you in the high risk group. And guide you from there and get you to the right doctors in the Seattle area who can help you decide whether, in fact, they think that your disease is outside of the gland.
I'll be there tomorrow night.
Okay.
Things like, so I was talking to Fred Hush and the UW today, so I'm trying to get scheduled through the VA community care.
Yes.
So all that's going good, but I'm not sure, if my 1 year old.
Okay, so here's what I would try and do, okay? If you can get in to see Larry Fong, because he is seeing patients now. We love him. I've worked with him since 2012. He's on our advisory board, but he's a very good doc. But he may not see you because, you know, he really does recurrent. Dr. Schweitzer is very good. So I think that, and I would not be going, I don't think at this point I would go straight to a radiation oncologist. I would really be wanting to get the view of a genitourinary medical oncologist. So I don't want to say more than that right now, but those are a couple of names if you want to try and get appointments. If it's anybody else, because they may try and push you off onto somebody with less experience, talk to us and we'll tell you if we know them and what we think.
Okay, they told me, I know those two people. They told me when I sat down with them Friday, it has to start with a radiation oncologist, and once they get it going to see the medical oncologist, but I have to see him first. That's what he said at the UW.
Who said that? The people at the VA or the people at UW?
He works at the UW and the VA. He's the one that did my biopsy. You know, he said you
well, that might be more of a VA requirement. It's not a UW. As far as it isn't a UW requirement.
So I should try to see one of those two guys. Okay, that'd be my first thing. Well, then that's what I'll work on.
I mean, I would want to talk to. That's what I would do. I mean, yeah, you can see a radonc. I don't know that we have a go-to radonc at UW. I'd have to see who some of our guys have seen there. But, you know, for me, the problem is that these guys, they want to do something, you know? And we've got to make sure that whatever they do is the right thing for you. But can we talk about this tomorrow?
Yes. The VA wants to feed me Lupron, and I already talked to Jim Marshall. We've been emailing back and forth. And
okay, can we talk about this tomorrow?
Yes, sir.
Thank you.
Okay, it'll be my first time, so I guess I'm a new guy in the high risk, right? The group I didn't want to join, but okay, sounds good. I'll be there. Thank you.
Well, you didn't want to join this one either, did you?
I kind of like this one, but I like the active surveillance.
Well, we're glad you came.
The best. Thank you. I'll be there tomorrow. Thank you, everybody. Appreciate it.
Good luck, Brian.
Thank you.
Good luck, Brian.
Thank you.
Some of us will see you tomorrow. So.
Yeah, feel for your brother.
It's the journey, man. It's a journey. But I got to say one thing. I feel a little bit relieved now. I feel a little bit relieved because now I kind of know what I got to do.
Yeah.
Okay. Thanks, guys.
All right.
And Brian, we've forwarded that PSMA information. I've seen it, but we forwarded it to the other two moderators. Dr. John is the lead moderator tomorrow night.
Okay. Thank you.
All right. Henry, are you there?
Which one?
Which one? Is there two Henrys?
I see another Henry on this.
Yeah, there's two.
Well, I see Henry whose mic was muted, but the Henry that said he wanted time.
Oh, that would be me.
All right.
Okay, so let's see where I'm at. Okay, so I saw Dr. Percy Lee last week over at City of Hope. Seemed like a good guy. Said he's done about 200 radiation on the MRI Liniac over there at City of Hope. I'm still undecided. I'm still waiting for the second opinion from Dr. Epstein. I signed a paper last week, and I'm hoping it's been sent, but I need to double check. I'm having difficulty finding anyone who can read the grid report from my decipher test. Dr. Lee could not really explain anything on there. Basically, what I'm being told, I've met with 3 doctors so far. Basically, they're telling me that that report can't be used for any kind of decision for treatment. So they just keep pushing me off on whenever I refer to it. I have one last meeting scheduled to go over this with Dr. Dorf from City of Hope, and I understand she's really good in this area. I don't know if anybody knows her.
Anya Dorf? Anya Dorf?
I believe so.
Yeah. So
She's
yeah,
a secure.
Dr. Dorf is not going to have any problem reading the grid report. Here's the point with the grid report. Yes, it's not supposed to be used for patients. You're right. But if you look through that grid report, you can see whether they've seen any mutations and whether their decision making is based on having tracked a mutation. Now, I haven't read a grid report. Dr. John has read many of them. But really, it's sort of above and beyond for us to be interpreting the grid report. At the same time, we've been known to do it generally in the high-risk group. But if in that grid report, in looking through, it tells you that they have seen, and I'm just taking an example, PTEN, or they have seen BRCA, BRCA, or they have seen MLH or MLS. That is an important decision-making factor for you. So when these docs say, well, it doesn't help you, it's because they don't want to take the time to look at it and read through it. I can't necessarily blame them. It's not their job. It's above and beyond, but it's something we do here, and why this is such a great support group and organization. But we don't necessarily, we don't have anybody who is a regular in this low intermediate who can read it for you and understand that, and the benefit of everybody who's listening. Most of the guys who are in here are volunteers. So they volunteer their time. And we can't ask somebody to volunteer their time, but they may be willing to do it, and they may offer to do it. And if they offer and they know what they're doing, it works great. So, if you've gotten, I will tell you, it's no easy feat to get a time with Dr. Tanya. She knows us very well. But if you've got a time with Dr. Tanya, the question you want to ask her is, Dr. Dorf, are there any of those bad actors? Do you see any of those bad actors in my decipher report? What's your decipher level, Henry? It's high, isn't it?
94, and we talked about the PTEN last time. I was high on PTEN loss.
Okay, so if you're high on PTEN loss, then that tells us a lot. It tells us that you absolutely, I don't want to say absolutely, but the likelihood is you need treatment, and and unfortunately, and she can probably tell you these statistics because I think she was involved with capivasertib and the Capitello trial. And the drug is called TrueCap, TRUQAP, that has been developed to address PTEN. But I think that usually it is used later in the disease cycle because the approval for capivasertib for prostate cancer, which happened about 3 months ago, I think it's used in conjunction with abiraterone. And so for you need to do treatment first, but be assured that, God forbid, your disease comes back, we've got a bunch of things that we can do, because the likelihood is you have PTEN. I think PTEN can be, it's usually somatic, but I think in very rare cases it can be germline. Have you had a germline test?
I did. I'm meeting with the genetic counselor, or whatever it's called, director, next Monday to go over the test.
Okay.
I haven't gotten the results yet.
You haven't got, okay. So those results will be really significant. And you'll please come back and talk to us about those results. And, you know, maybe you're maybe if you do carry a germline mutation, we have a whole bunch of programming for people who are in that situation, and we'll help you with it.
Also, bring up the Prostox. So both UC Irvine and City of Hope will not order the Prostox. So they only said that my option was go to UCLA and get it from them. Does that sound reasonable?
Yeah, I mean, I'm surprised UC Irvine won't do it. I don't know what their reasoning is. I mean, what I would do is write to the Prostox people. You can drop Dr. Weedhouse a line and say, you know, you want this test, and neither City of Hope or UC Irvine is willing to order it, and how can you get a copy? I mean, you heard earlier on, Jeff was saying that Dr. Vapiwala wants to order it for him. So, right. You know, you've got Dr. V on the other side of the country who says, yes, we should get your Prostox test. And we got people right here in California who are being...
Yeah, Dr. Lee said that he said he found no use for it based on the studies that he read off.
Yeah, well, that's why I'd rather see Dr. Vapiwala than Dr. Lee.
Yeah. That's who I have. All right.
You know, there's too many people in this country, in the medical institutions, who have found a use for it.
Right.
And the bottom line is that it may help the patient. And so when we get doctors like that, and Lee is good, but we get doctors like that, we have to work around them.
Can you just order it yourself? That's what I did.
I don't know.
I watched the webinar you have on the website, and it sounded like it had to be ordered from the doctor based on that webinar. I don't know if it might have changed since then, but I can try and contact them and ask.
I got it as an international patient, so it was maybe a little different. It was quite cheap, actually.
Just a cheek swab.
Yeah.
How much was the test for you, Steve?
I think I got both, you know, the SBRT and IMRT, and I think it was 900 for the pair of them.
That's reasonable.
Yeah. It's worth having.
Relatively cheap. I mean, there was a time in my life when that was definitely not cheap. But
yeah.
Yeah, compared to the cost of the SBRT, my God. Yeah.
Well, my PSMA PET scan was 50,000, so that's on the bill.
Yeah. David's had his hand up for a while. David, you want to ask him a question or a comment?
Yeah, well, you guys just prompted a question, but what is the Prostox test?
The Prostox test is a test that will give you an indication of whether or not the radiation treatment will cause certain levels of toxicity to you. Rick, you wanted to explain it better than me, or?
No, that's fine. That's enough. Fine.
I think Stuart's probably a better person to explain it than me. I know what it does, but I don't. Stuart, you want to say anything about the Prostox test?
No, I was just looking because it used to be patients could order it directly, but the requirement was they had to send a copy of the report to a doctor. Prostox test tests for long-term sensitivity, the higher risk of long-term side effects from SBRT radiation. And I think, if I remember correctly, it's about between 10 and 15% of the population is at high risk for the side effects. So the purpose of the test is to flag and wave you off SBRT if in fact you fall into that minority of the population that displays the risk. So as everyone said, it's a swab test, and it really, it's a very simple, do you have a risk or not? And if you're considering SBRT radiation, it's a no-brainer to want to get that test.
Yeah. Unless you're Percy Lee.
Yeah. Well, that's what I'm trying to see is if you can, if Iridex still allows you to order it directly, you could find a different doctor to receive the test. It doesn't have to be your treating urologic oncologist.
I mean, I think what I suggest to you, Henry, is to call MiraDX, who make the Prostox, miradx.com, miradx.com. I'll put it in the chat window, and call them up and say, you want this test, but neither COH nor UCI will order it for me. How do I get it? And you won't be the first,
Okay, I'll do that.
I'm looking at their website as we speak. And okay, here's the telephone number. Oh no, that's for patient billing. Here's the telephone number. You tell them AnCan referred you because they know us pretty well. And there's a telephone number for you.
Okay. Then my last question is, I was at UCI today at a meeting with an oncologist, and she was telling me about about getting my second PSMA PET scan before I get treatment, and that their imaging equipment was the best in the country, the newest. Is there really a difference between the type of equipment between maybe UCI and City of Hope in terms of where I get my PET scan?
That's above my pay grade.
Yeah, I can't answer that question. I'm not familiar with the equipment that they have. I mean, they're both good facilities, and I would think that they would both have good equipment. So,
yeah.
But who is it that you were speaking to today at UCI? Did you say is that the radiation oncologist or the?
No, that was
Lee there.
Yeah, that was Lee. That was last week. No, this was a Dr. Marr, M-A-R, at the UCI. She's a medical oncologist.
And what sort of doctor is she?
A medical oncologist. I found her
She's
because
a medical oncologist.
Yeah,
so
she also does speaking and knows Dr. Dorff, and they're friends.
Okay. So I don't know her, but there is yeah, she's working. There, I think I mentioned to you, I gave you a name. There's another lady there.
Yeah, very long name. I think I may have seen it.
No, not a long name, not a long name. Let me look up somebody who I know consulted with.
Okay.
That's okay, because I'm gonna see Dr. Dorff next week, so that I think that should be it.
Henry, I just put in the chat the link on mirakyne.org for their prostox.registry. If you go to that page, it specifically says that if you can't get it through your provider, that you could get it directly from them. There are a couple of conditions that that you can't have already been treated, and there's a couple of stuff which probably don't apply, and it's $500 for the test, and they can provide it directly. So take a look at that link.
Yep, I got it. $900 for both tests. It hasn't gone up, at least.
All right. Someone, David in Portland, you have your hands up.
They do. Prostox does also offer financial discounts.
You gotta prove that you can't pay or something like that, or?
Well, you have to submit information on your income. Yeah.
Oh. Yeah. They tell me that I have to pay full price.
Sandy Lou was the other doctor that whose name I was trying to remember. But,
all right, Henry.
But Henry, you can't do a lot better than seeing Dr. Dorff.
Yeah. No, thanks.
All right, we're gonna move on. We only got one more person that wanted time. Albert, are you still with us? You said that you had an appointment.
Yes, I started my Orgovix just today, and so far so good. And yeah, I do mapping the 31st, and then treatment the 9th, then 5 treatments, Dr. Kishan, SBRT, MR Lineac. Anyway, I'm still conflicted. I hear people talk, and it's like, well, like you're talking about Dr. Vapawala talking about, well, she'll talk about the different types of radiation rather than pitching the one she does. Well, I talked to 4 or 5 different doctors, and they all said to do a different one. And
but the important thing now is that you've started the Orgovix, you've got an appointment for your first treatment, and for mapping and your first treatment, just go forward with it, Albert. I mean, don't second guess now. Don't just go, man.
I just got through it recently, and it was an easy ride, actually. I mean, the Orgovix is not easy, but the actual treatment is quite straightforward.
Okay. I have this haunting concern that because Rossi said, do brachy and beam, and I'm like, it's not going to be enough. It's going to come back. So I guess that's before I've even had treatment remorse.
Yeah, you can't have treatment regret before you have treatment. So don't even think about it. And again, I've told you guys my philosophy over and over again. Treatment regret is useless because you never know what would have happened if you chose the other treatment. In the multiverse, that's a whole different world, right? Yeah. You'll never know.
Yeah.
I went through the whole HDR and MR Lineac kind of thing too, but I ended up having a high decipher score, so I actually demanded ADT, and Chang, who was doing the HDR, wasn't really supportive, and he barely even implemented it as part of his protocol. So I kind of, that was to me the defining thing.
Yeah. Actually. Yeah. Right. Well, also,
I think keep in mind actually is, in some ways, HDR is more targeted, but that can be both a positive and negative. If you're worried about spread, like I was a little bit, I like the idea of it being a little wider. you know, the margins, I guess you could say the margins, but really the dosimetry is a little bit wider, you know, plus
with the beam, with the beam.
With the beam, yeah.
Yeah. Oh, that's good to know. Yeah. Right. Okay. That's reassuring. Yeah. And as I said before, you know, I'm in this Manticore trial, and I don't know if I'm going to get the adaptive or not. And I'd rather get it, but I talked to Kishan about it, and he was like, "Well, if you don't get it, we're still going to be better than anybody else that does that would do the adaptive for you with MR Line X." So
I'm not sure what that is, but,
what's that?
I had the, you know, the focal treatment. It wasn't part of a study per se, but it was, you know, on my DIL because I had predominantly on one side. But I also was part of the Vortex trial, and I don't know which I got either.
Yeah.
But that was to try to avoid your penile bulb, and
right.
I don't know. You know, on an ADT, you can't tell whether it did anything, but
right.
maybe eventually.
You say you had more focal. It was still MR Lineac, but he focused on the lesions like a boost.
Yes.
Yeah. Does he do that standard?
They literally target the lid, you know, the actual lesion, and they boost it by, for me, it was 42 gray versus 40 overall.
Okay. I guess that's a matter of course.
I think so. I mean, I would ask him about it because he addressed it for me.
Okay,
yeah. Albert, I'm going to ask you the same thing. I'm going to tell you the same thing I told Steve. I'm going to ask you in 10 years how you feel about the treatment that you got. So.
Okay, cool. Love it. Thanks, guys.
So, David, you have your hand up? You're muted, David.
No.
I don't know how to unmute when you're on the phone. Does anybody know how to tell them what to do? I know how my phone works. I don't know how other people's phone works. So, there is a mute button in the go-to app on my Android.
Yeah.
So hey, David, this is Boykin.
Sorry.
On an iPhone, you just press the mic button to unmute.
He got it.
I got
David,
it.
Go ahead.
I got it. I'm just in the car. Sorry. I had a comment for the person who was asking about the Decipher test. I've looked into mine pretty deeply, and I'm working with Dr. Liss at UCSD. I worked on similar tests in the industry. Broadly, unless you see specific mutations that are already known in that test, they seem to be grouping your cancer into a similar group of cancers and predicting the outcomes, treatments, etc. Whether radiation therapy might be useful. I'm just speaking with regard to my test so far. It's based on, it seemed to be 8 to 12 different literature tests. And in my case, my Decipher score was 0.49, so literally like 50-50. But the individual tests, they give you the component from the different literature references, and mine ranged from 3 to 85%. So effectively, to me, that is useless for my purposes. You could go either way. So it seems to be a chip test. There's a heat map in there that provides different colors of which genes are expressed more highly and lowly. I don't think you're going to find anybody who's really looked at the individual components of all the genes they test, other than the specific mutations that they can look for that are known to be associated already. And so, that's as far as I've gotten with it. I'm going to pursue it a little bit further with the scientist at Link. Is it Link? I can't, or Verisight. It might be Verisight.
Verisight.
Yeah. So.
Are you talking specifically about the grid report, David?
You're talking about the heat map, the colored different stripes?
There are a number of screens in that grid report. I have not seen one, so I can't tell you what's in it, but we're talking about the grid report, not necessarily the mechanics. of the Decipher test, but the additional information that's generated in the grid. Are you familiar with the grid report?
I was trying to pull mine up and open it, but I'm driving right now, so it's not really possible. Which part of the long form? I read the whole long form report, which is somewhere.
So no, this is an additional report that is available on request only. The request has to come from your doctor, but they are willing to send it. They will send you a copy, but your doctor has to request it. And
are you sure? I think that was the long form report that I already read.
Well, it
did come from my doctor. They've told me, and my doctor, this is hysterical, but they got the color report in, and his office protocol is to scan all the incoming mail and shred it immediately.
Okay,
but
so
they scan it in black and white.
David, no, I can only tell you that we've been referring to this as the grid report, and Decipher talks about it as the grid report for the last year and a half or more. So what I would do is ask your doctor if he got the grid report. If he says, yes, that's what I send you, then that's what you're calling the long form. We can't tell you if the long form is the same thing as the grid report. We can tell you that there is a report called the grid report, which is a more extensive report that is available from Decipher. It has printed all over it for research only.
Of course.
Did your long form report have the annotation for research only on it?
I can't pull it up right now, but
You don't remember if you saw for research only on there? You don't recall if it said for? I
promise you, having been in the industry, I ignore that stuff.
I know you've been in the. I know you've been in the industry, and
I know
we
you like
respect
to
you
shout.
for that. But what I'm saying to you is, David, that industry or no industry, you can't fail to notice that it says for research only. You can choose to ignore it.
That's a comment
Henry,
about FDA
Henry, you had your hand up. How can we? What were you going to say?
Insecure.
I was just going to say there's all 8 pages of it says grid report in the top left corner.
Right. So you can't miss it, David. Even if you're in the industry, I don't think you can miss it.
That comment in the industry relates to FDA approval. That's what
David.
It's a comment.
This may not be the right group for you, David.
So glad I can contribute.
All right, guys, we're going to carry on. We don't have anybody else that wanted time tonight. So if there was anybody that wanted to chime in here at the end, let me know. Nobody? As we say in the military, silence is consent.
I'm trying to think if there's anything else we need to cover here, Bill. I'm looking to see who's here. David in Portland, please be advised that we are honing in on a webinar for families that carry a germline mutation on August 31st.
Oh, okay.
It will happen. We have one genetic counselor tied down already, and we are looking for another genetic counselor. We think we have one, and I'm hoping Dr. Munster is going to take a role in it, but she just changed jobs on the 1st of the month, so we haven't actually, I didn't want to bug her. So that's something for her.
Where'd she go to?
Stanford. She's moved after some 20 years from UCSF to Stanford.
Good to know. Thank you.
And I don't know exactly what she's going to be doing there. I haven't had a chat with her about it yet, but you know, we're excited for her. Brian, we've everybody who needs to see it will have gotten your PSMA report. We do an intake. Bill, I don't know if I have Brian's email, but can we send him the intake form?
I only have one for the low group. Is there?
Oh, you don't
one for
have the high risk group?
I do not. I'm sorry.
I watch a lot of the high risk YouTube videos.
Okay. Anybody else? Stuart and Colonel Boykin, you've been very quiet, both of you. Anything on your minds that you'd like to talk to the group about?
I'm good.
I'm good.
I got a question.
Okay.
I got a question.
Go ahead.
I have an alibi. I want to say, Albert, congratulations.
Yes. Yes.
It's lucky. Hey, Albert, it's lucky that Boykin wasn't driving. He might have gone straight off the road when he heard you say you had an appointment.
Climbed the telephone pole with the car, huh?
That's right.
Yeah.
What?
Brian, what was your question?
I thought the veterans group was once a month. Is that not true? Is it every 2 weeks?
Yeah.
Yeah. Which veteran? The veterans benefits group, right?
Yeah, with Jim Marshall.
Yeah.
Is that every 2 weeks, and is it recorded or not? Is every other one recorded, or how does that work? I thought it was once a month.
No, it's the first and.
Yeah, Brian, it's recorded, but I've been backlogged.
Oh, okay. But it's
first and second Tuesday of every month.
Yeah.
Oh, I didn't know that. Okay. First and second Tuesday.
At 8 p.m.
Wait a minute. It's not the second Tuesday. I think it's the first and third Tuesdays.
I'm sorry,
Bill.
First and third Tuesday of every month.
The first and third Tuesday, and then the Veterans Speaking Freely group is the fourth Thursday. Is that right,
Once
Bill?
a month. Yeah, once a month on the fourth Thursday. Brian,
yeah,
the benefits one is in the Schmear room, so you can find the link on our events calendar on our website.
Yep. Okay.
Yeah, all this information's on the events calendar. It's all there. We work very hard to make sure that you guys have all the information you need.
I'm too busy watching all your old videos.
All right.
High risk, too busy. But I'll check it out. Thank you. You guys are awesome.
Brian, don't worry, we have your back.
I'm stressed out.
We have your back.
Thank you. I know. I feel that.
And we'll make sure you get the right treatment from the right people, for sure.
They're going to call me tomorrow and would try. Did you want it at the University of Washington or Fred Hutch? And I go, I thought they were all the same. And then my doctor says I got to see well, we'll talk about it tomorrow. But
okay,
yeah. But they're going to call me tomorrow, so I got to kind of figure it out. But so I got to start with a radiation oncologist, and then we can branch off. But I don't know.
Yeah.
It'll work out.
All right.
I'll see you guys tomorrow.
Wish you
Thank you. So, hey, Rick, does that mean I can't go to active surveillance anymore?
You can go to any group you want here. It's what we talk about in the group.
I just gotta shut my mouth, right?
You're right. So you're very welcome to come to this group, and you're very welcome to go to AS. But and you were in active. How many years were you in active surveillance?
Man, I just got diagnosed last August, but I've had problems since 2020. Since 2020.
Okay.
But
2020. So, you can, but you feel free to go to anyone. It's just that we don't like to freak people out.
I know.
And they come in and they want to hear certain things, and they don't want to hear other things.
I'm with you. Right. I hear you 100%.
Yeah, there's a rhyme to our reason. We have a reason for why we separate the groups, and we think it works pretty well.
Today I got an email from a huge donor, one of our biggest donors, and his wife has recently been diagnosed with a preliminary form of breast cancer. And he asked me about, do we have any groups that we can recommend women's breast cancer, which we actually don't, because we're really not in that space. But what I did say to him is try and find a group that's equivalent to our active surveillance group, because she doesn't want to go into that group and listen to people that are having chemotherapy and having mastectomies and this, that, and the other.
Exactly. Yep.
You know, so that's the reason we do that.
All right. If nobody objects, I'm going to stop the recording. You don't have to leave. I'm just going to stop the recording.
I object.
Yeah.
Just kidding.